Thank you very much. Appreciate the opportunity to speak with all of you again this year. Enjoyed being here at the conference last year. So I'm going to talk to you today about syncope and sudden death in children and adolescents. Okay. So first I'm just going to start with syncope. Syncope is basically a sudden and complete loss of consciousness with recovery within a few minutes. This is a very common, a very common symptom and complaint we see in the pediatric population, especially in the cardiology world. It can occur, in a frequent number of children, especially adolescents. Oftentimes the symptoms are out of proportion to actually what's going on, especially from a parental standpoint. So there's a lot of anxiety that goes around syncope, especially with media and news reports of people having more significant issues, and we'll talk a little bit more about that in the second part. Really, we feel like syncope is significant if it's a repeated event or if you have children that what we call face plant, meaning they incur an injury with no warning, it's sudden, unexpected, and they're at risk of having significant injury associated with it. Syncope, again, is a common complaint. It's a sudden onset and a transient loss of consciousness and a patient's postural tone. And again, it's very disruptive out of proportion to the severity. Many children will have pre-syncope, which is either a sensory issue or some kind of dizziness or postural impairment without any loss of consciousness. So that's a common complaint that we see as well. It's an interruption of essential energy substrates to the brain. Common forms of syncope are more frequent during adolescence, with nearly 80% or more of the children that are referred for syncope have a neural-mediated response. Also, a lot of times family history is important because you will see that there's a positive family tendency to faint. Oftentimes it's in the female side, moms, sisters, aunts, more common in a first-degree relative, although I've occasionally had some dads that were fainters as teenagers as well. Again, the pathophysiology is a sudden dysregulation of your cerebral vascular tone, similar to when people have migraines or they hyperventilate. It can be due to an overwhelming drop in your perfusion pressure. That could be due to something like an arrhythmia or any kind of cardiac inflow or outflow impairment. There can be an overwhelming drop in preload, like if somebody's significantly hypovolemic or they have problems with an autonomic neuropathy. Or you can have an overwhelming drop in your arterial resistance. Again, that's usually what we see with neuromediated vasodepression. The most common cause in young people is neuromediated syncope, or goes by other names, neurocardiogenic or vasovagal. We also just refer to it as the common faint with most of our patients. Again, the disturbance of the autonomic control of your heart rate and blood pressure is sort of dysregulated. It can be due to emotional events, pain, postural changes is very common, changing positions, or a variety of just normal functions of everyday life. With the normal autonomic responses, you have afferent signals in the medulla that are concerned with your regulation. The stretch receptors will increase the firing, which will decrease your sympathetic tone and increases your parasympathetic stimulation. As a result, you get vasodilation and decrease in blood pressure. Then you'll have a drop in the heart rate that follows. Postural changes and patients that are hypovolemic or don't drink a lot or are pretty dehydrated will have the opposite effect. The theory seems to begin with your beta-adrenergic hypersensitivity after you have subtle changes in your posture or your volume. It increases your baro and mechanical receptor firing, and then it's followed by an alpha-adrenergic withdrawal, and it enhances your parasympathetic tone, which in turn then will drop your heart rate and drop your blood pressure. This is just the old reflex pathway that we all learned in medical school. I won't go into that in too much detail. Sometimes this syncope can be caused at the site of blood or if a patient is experiencing pain or they anticipate that they're going to have pain, like a blood draw or a vaccine or a needle stick or something like that. It's very similar pathophysiology. The catecholamines stimulate a higher release from your cerebral center, and again, starts to stimulate your reflex withdrawal and your parasympathetic activation. Some of the symptoms that are associated and common prior to syncope would be weakness, tiredness, lightheadedness, yawning, feeling hot. A lot of kids will describe blurriness in their vision, where their peripheral vision has spots. Nausea, palpitations, those are all pretty common symptoms associated with it. Most patients will recover quickly. If somebody tells you that they've passed out for 10 minutes, an hour, it's not related to this type of process. They also may experience symptoms of persistent elevated vagal tone. I've found this over the last 20 years that I've been practicing is a very common complaint. Early on, I used to think the kids were nuts, but I think it's actually a real phenomenon that they tell you that over the next day they feel tired, they're nauseous, they feel like they've been run over by a train, they're very fatigued. And that seemed to be actually a very common finding after kids will have, what's described as a very brief episode. Sometimes we'll see tonic posturing or clonic jerks within 10 seconds of the syncope, and that oftentimes will alert you that there may be sort of an asystolic form to it, that the heart rate and blood pressure drop low enough that they're actually asystolic for several seconds, and they'll have some jerking motion. The causes of syncope can be neurologic, they can be metabolic, or cardiovascular. The neurologic causes can be from seizures, reflex type of causes, which we spoke about, psychological causes, which can be common, kids that can have like panic attacks, anxiety attacks, conversion reactions can also provoke syncopal type events as well. And again, those symptoms are going to be relatively out of proportion to what the actual pathophysiology is. CNS events like seizures, migraines, head trauma, hemorrhages, kids that have maybe hydrocephalus or have had shunts and have shunt malfunction can also develop these symptoms. Psychiatric causes, hyperventilation can obviously cause hypocapnia. Kids might describe that they're getting hand numbness and tingling, and you want to think about kids that hyperventilate in association with this, and syncope from vasoconstriction. Conversion reactions is more common in girls than boys. The patient does not injure themselves. It's usually in the presence of others. There's usually no preceding symptoms. And again, their unresponsiveness continues even after they've passed out and attained the supine position. So that should be a sort of trigger to you that there's more going on than just the normal syncopal type of episodes. You can reproduce it with tilt table testing in someone that has an absolutely normal blood pressure and heart rate. So obviously you're not producing the pathophysiologic findings of syncope in someone that's sort of faking it. The treatment obviously for these kind of kids would be psychiatric intervention. The metabolic causes, obviously there's many drugs, both medically and non-medically prescribed. Cocaine can be one, obviously that's not medically prescribed, that can cause this. Endocrine type of issues, medications that affect your serotonin reuptake, protein issues. Antiarrhythmics or proarrhythmics, medications that cause that can precipitate syncopal events. Medications that cause sinus bradycardia or AV block, like if you overdosed on a beta blocker, or patients that might be on digoxin. Hallucinogens, barbiturates, opiates can cause syncope with or without hypotension. And cocaine, syncope in about 27 to 30% of heavy users. And obviously this is also a cause of sudden death from ventricular arrhythmias and myocardial ischemia, so sort of the ultimate bad from syncope. The metabolic causes can things that impair your substrate to the brain, like hypoglycemia. This sometimes is overdiagnosed. A lot of times people will tell you, oh, I'm passing out because I have low blood sugar and things like that. If it truly is due to that, it's usually preceded by weakness or hunger, diaphoresis, pallor. Should be considered obviously in patients that are diabetic or in individuals that have some type of metabolic derangement. Cardiovascular causes, which we'll talk a little bit more in depth when we get to sudden death. Structural causes, like anyone that's born with a heart defect. Functional causes, like arrhythmias or rhythm disturbances. And then neuromediated, obviously, which is a big group of these patients that we spoke about before. Structural disorders, the obstructed lesions like aortic and pulmonary stenosis, patients that have tetralogy of Fallot that have significant pulmonary stenosis, so outflow tract problems can be at risk for syncopal episodes. If you have low output, like someone that has severe mitral insufficiency, that also can cause syncopal episodes due to orthostatic intolerance. Aortic stenosis is probably one of the most common ones that we worry about due to an inadequate stroke volume. They also can have subendocardial ischemia, and they're more at risk of ventricular arrhythmias. Okay, so leading into that, we're going to then talk about sudden death. Sudden death is defined as a death resulting from an abrupt loss of heart function. It's unexpected and may or may not have had a previous heart history. 80% of sudden cardiac death occurs in individuals that have coronary artery disease. The vast majority of those are patients that we don't, deal with in our population because mostly children have healthy coronary arteries. 60 to 85% will have VFib as their initial rhythm by the EMTs. 20 to 30% will have asystole or a bradyarrhythmia at the initial contact. And only really 7 to 10%, a small percentage of that, have sustained ventricular tachycardia at the initial episode. And those, fortunately, are the ones associated with the best prognosis. The problem being is that they're the smallest group of patients that present with sudden cardiac death. It's about 0.1 to 0.2% per year in the adult population in the United States. It accounts for about 300,000 deaths per year. It accounts for about 50% of the deaths from coronary artery disease and is often the first expression of someone that has coronary artery disease. Even in ideal situations, meaning you have a competent person that's able to perform basic life support, you've got an automatic defibrillator on site or at the place you are, only 20% of out-of-hospital arrests will survive to hospital discharge. So it's still a significant proportion of mortality associated with this. The most important determinants of survival when you arrive to an emergency department is if you have a blood pressure greater than 90 that's unsupported, meaning you're not on inotropes and other medications. The time from your loss of consciousness to return of spontaneous circulation is less than 25 minutes, and you have some form or some movement of neurologic responsiveness. 30 to 80% of patients that present with sudden cardiac death will have anoxic encephalopathy. In our population, African Americans greater than Caucasians have more risk. Men are 3 times as more likely to have sudden cardiac death than women. And your age parallels the incidence of the sudden cardiac death, but the proportion will decrease with age. So the younger you are, the higher chance you have of sudden cardiac death associated with coronary artery disease. 45% of people that present with sudden cardiac death have been noted to be seen by a doctor within 4 weeks of the event, and it's usually for a non-cardiac complaint. A prior history of someone that has LV dysfunction, meaning you have an ejection fraction that's less than 30 to 35%, is probably the single greatest risk factor for sudden death. If you have a history of frequent ventricular ectopy, meaning in either a Holter monitor, an EKG, you've had more than 10 PVCs per hour, and then any and all risk factors associated with coronary artery disease, family history, smoking, high lipids, hypertension, diabetes, obesity, and sedentary lifestyle all increase your risk of sudden cardiac death. If you have a past medical history that's significant for, obviously we've talked a little bit about coronary artery disease, but cardiomyopathies, valvar disease, a history of long QT syndrome, either caused by a family history or medications that induce long QT, Brugada syndrome, which is an arrhythmogenic RV dysfunction, or WPW, which is a rhythm disturbance with rapid conduction. When we look at post-mortem findings, atherosclerosis is the most common finding. In survivors, 40 to 90% of the patients have greater than 75% coronary stenosis in at least 3 to 4 vessels at cardiac cath. At autopsy, only about 20% show evidence of a recent MI, and 40 to 70% show evidence of a healed MI. Non-ischemic dilated cardiomyopathy is the second largest group of patients who experience sudden cardiac death. This can be due to viral causes, autoimmune, genetic, or environmental. The predominant mechanism for death in this population is ventricular tachycardia. You can see bradyarrhythmias late in advanced LV dysfunction. The predictors of sudden cardiac death in this population is, and number one is the increase in end diastolic pressure and the wall tension. They also have increased sympathetic tone, electrolyte abnormalities, problems with their neurohormonal activation. Non-sustained VT and ventricular ectopy are not predictors of sudden cardiac death, as in like an ischemic cardiomyopathy. However, if it's sustained, and they have a history of syncope in the past, those are important factors. This is just an example of an echo where you see a dilated left ventricle, aorta up here, and you see this stretched dilated left ventricle. Hypertrophic cardiomyopathy, which is an autosomal dominant condition with incomplete penetrance in some patients, is the number one cause of sudden cardiac death in younger people, or people under the age of 30. So this is more what we experience. Most of these kids and young people are asymptomatic, and it's also the number one cause of sudden cardiac death in athletes. The mechanism of their presentation of sudden cardiac death is not totally understood. There's probably a post-exertional blood pressure drop with shunting of the blood to the non-cardiac tissue, which worsens the outflow gradient and potentially causes cardiac arrhythmias and ischemic events. This is an example of a pro basketball player from many years ago, Reggie Lewis, who had hypertrophic cardiomyopathy. This is an example of an echo picture where it shows a very thickened septum and posterior wall, and during systole, this thickness of the left ventricle can cause outflow tract obstruction to the aorta, which can lead to ischemic changes with the coronary artery blood flow as well as arrhythmias. Arrhythmogenic RV dysplasia, which is not a very common cause, but something we do see in the pediatric population, is where the RV wall is basically replaced with fibrofatty tissue. You can have chromosomal involvement on 1 in 14. It can be autosomal dominant, so we do see this genetically related to families. 30% of the cases can be familiar. The annual rate of death in patients with this is about 2%. This shows you an echo where you basically see these black lines here. This is the right atrium up here, the right ventricle down here, the tricuspid valve, and you see this thinning of the RV free wall, which can lead to arrhythmogenic problems. This is a cardiac MRI, and you see up here where the arrows are, this fatty deposition of the RV free wall, which is kind of pathognomonic for this disease process. You get right ventricular hypertrophy and dilatation, which can lead to either monomorphic or polymorphic ventricular tachycardia. 25% of these patients will also have atrial arrhythmias. There's an abnormality that's seen on the EKG that's sort of pathognomonic for it, which indicates late RV activation. It's this little epsilon wave that you see after the QRS pattern. And again, if you see that, that could be pathognomonic for RV dysplasia. In the pediatric population, previously recognized congenital heart disease, including repaired heart disease, is a major factor that can lead to sudden cardiac death. In tetralogy of Fallot, about 10% of patients postoperatively will be at risk of ventricular arrhythmias that can cause sudden death. Transposition of the great arteries in which they've had coronary artery reimplantation can pose them at risk later in life. Patients that have had a Fontan operation for single ventricle physiology can have atrial arrhythmias that can then compromise their ventricular function. Again, we've talked about patients with aortic stenosis, patients with Marfan Syndrome or connective tissue disorders, Eisenmenger syndrome, which is severe pulmonary hypertension, can lead to bradycardia or VT and VF, patients with congenital heart block or Epstein's anomaly. In the acquired heart diseases, patients that have had Kawasaki's or dilated cardiomyopathies due to viral processes or myocarditis are at risk. Previously unrecognized heart disease with structural causes. Again, we've talked about hypertrophic cardiomyopathy. Patients can be born with congenital coronary anomalies that can cause sudden cardiac death, and we've talked about the arrhythmogenic RV dysplasia. Previously unrecognized heart disease that is not associated with a structural heart problem can be most of the rhythm abnormalities like long QT, WPW. You can have primary VT or VF, primary pulmonary hypertension, or commotio cordis, which results in a VT or VF event. Long QT is thought to be secondary to genetic alteration of the channel proteins that regulate your potassium flux during repolarization. 30% of patients are identified while being evaluated for a syncopal event or potentially an aborted sudden cardiac death event. The highest risk for sudden cardiac death are those with deafness or a first-degree relative that's had sudden cardiac death. It can also be associated with emotional extremes, auditory aura stimulation, and vigorous physical activity. Idiopathic long QT is due to a prolonged QT with a propensity to develop malignant ventricular arrhythmias. This is a fairly rare familial disorder. Congenital long QT syndrome, there's two types. Jervell-Lang-Nielsen syndrome is associated with deafness and it's autosomal recessive. Romano-Ward is 90% of long QT syndromes. It's autosomal dominant with variable penetrance. I always tell medical students the way to remember the two is that Romano-Ward sounds Italian, and Italians are strong dominant people, so that's autosomal dominant. There's no associated deafness with Romano-Ward and can be involved with several identified chromosomal gene defects, the SCN5A, the 7-HERG, and the 11-KVL-QT. These are now genes that can be diagnosed with gene testing. For congenital long QT, you need one major and two minor criteria. The major criteria is that you have long QT on EKG or you have syncope induced by stress. Minor criteria would be congenital deafness, having T-wave alternans on your EKG, or significant bradycardia in children. Acquired long QT can be due to medication, so you want to be careful, especially in someone that potentially has already prolongation on their EKG. Some of the class 1 antiarrhythmics, the class 3 drugs, and a lot of other drugs like antidepressants, antihistamines, erythromycin, Bactrim, a lot of those medications can cause prolonged QT. You can have electrolyte abnormalities that can cause acquired long QT, like hypokalemia, low mag, or low calcium. Nutritional deficiencies can also cause it, like fad diets, starvation-type diets. WPW, or Wolff-Parkinson-White, which is an arrhythmia that we see in children and young people, is a fairly rare cause of sudden cardiac death, but some people are at risk of developing AFib with a rapid response over the accessory pathway, which can induce VFib. The factors that can increase that risk for children and young people might be that they have multiple accessory pathways, or they have a posterior septal pathway, or they have pre-excitation with an R to R interval of less than 220 milliseconds. So a lot of these children, when they are identified and they get a little older, we will actually send them for electrophysiology studies to study their pathway and their risk factors for sudden death.
One more minute.
Okay. Brugada syndrome can also cause sudden cardiac death. It involves right bundle branch block and ST elevation. There's typically no structural heart disease, and it's an issue with the cardiac sodium channel. I'm just going to skip through some of these. See if I can get to the end. Okay, Marfan Syndrome, which is a connective tissue disorder of the fibrillin gene, can cause dilation or significant dilation and enlargement of the aortic root, can predispose patients to aneurysm formation and sudden death. That's it.